This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Right, good morning everyone. I think we'll get underway. Thank you all for coming. We've got a great sized audience this morning for our Journal Club session, our Global Journal Club. So the idea of this session is that we're going to demonstrate why evidence is taken up differentially across the globe. Okay, so we're going to be looking at what some of the recent papers, 4 recent papers that have been published, and we have some expert opinion and discussion on those. What it isn't, this session, hopefully, is a session actually describing the whole of the paper. So we've got a couple of brief slides looking at each of the 4 papers. Oops, hold on, we've got fly-any things. But it's not really an in-depth analysis of each of the papers. So hopefully it's a light-hearted discussion, looking at, what we can take home. It's a bit hard to see this. So, Neil Orford from Geelong is going to introduce the panel to us.
Good morning, thanks for coming. For those of you who've been following Twitter, you'll probably know there was a little bit of pre-panel shenanigans going on with Jack trying to coerce other members to be off their game this morning. That hasn't happened. So can I welcome Jack Iwashyna from Michigan, who you've all been introduced to already, who's over here for 6 months, so he's sort of an Australian, so we've already got an advantage. Jack, if you could come up on the stage. A bit of applause, come on, let's give it up. I wasn't going to do strobe lights for you because you're American and you like big, things.
Smoke machines are far.
Yeah, that's right. Second, more dignified panel member, Jean-Daniel Chiche. And our third local Aussie battler, Associate Professor Dave Gattas from RPA in Sydney. Now you may think these guys have nothing in common other than being white males, and but they do have something in common. That is, none of their countries can beat the All Blacks.
And none of us.
That could be the first discussion point.
And none of us speaks proper English.
Yeah, okay. So we'll get underway with the first study.
Okay, so the first study today that we're going to debate furiously in a short time. Can you guys see? No. Okay, that's all right. It'll be a blinded discussion.
We don't need the data to drive our opinions.
No, true. In fact, let's not even worry with the paper. So this is the warm-up. This is the targeted temperature management paper from 2013 by Nelson and colleagues. So this study, we'll just have about 4 or 5 slides discussing the basic study. So looked at unconscious patients post out-of-hospital cardiac arrest, 36 ICUs, and there was 950 patients who were randomised throughout Europe and Australia. And what they did was randomise them to cooling to either 33 degrees or 36 degrees for a period of 36 hours. Following that, they underwent blinded blinded brain analysis, about 72 hours after the cease of intervention. They found that there was no difference in relative risk of death or bad neurological outcome. They had a composite outcome of poor neuro thing and death, and no difference in any of the secondary outcomes either. Sorry, just these little flying things. So here we are, Kaplan-Meier curves showing that there's no risk difference in death. What the study did show, and some of the secondary outcomes, was that there was a lot of bystander CPR undertaken, mostly shockable rhythms, and that there was actually a very short time to CPR, so a median of about a minute, which is fairly quick. So there's some criticism and failure to adopt, possibly around perception of the sort of BLS and ALS components of this, and that downtimes might not be similar internationally as were found in this study. So here's your first chance to have some input. Get your phones out. What temperature target do you use in your current practice for the first 24 hours for post-cardiac arrest survivors. So do you control hypothermia down towards 33, 34 degrees still? Do you target more of normothermia around 36 degrees? Do you avoid hyperthermia? Or are your patients really hot and you just kind of let them do what they like? Okay, so the live polling result will come up sometime. In the meantime, gentlemen, where would you like to start? So is it, I think a lot of people had quite firmly held beliefs prior to the TTM result coming out, and how does this change beliefs? Is it easy to change beliefs? Who would like to start?
So I think one of the first things I noticed about this study is it seemed like a good part of the world to have a cardiac arrest. So I thought the outcomes generally were stacked up reasonably well. I can certainly speak what I thought of this, and what how my department sort of understood the result is, as a department, we went back to 36 for somewhat pragmatic grounds. As well in the same department, we also wonder if there are we still wonder if there's certain subgroups within that population which it may be of benefit. So I hate to start with a great compliment to one of my panel members, but Jack just gave a presentation about heterogeneity, and I guess the potential effect of interventions really depends on the kind of populations you're exposing them to. So big studies which take on all-comer populations might tell you about the general situation, but in my ICU we're also getting into ECMO CPR. So in the case of persistent cardiac arrest, and Steve Bernard certainly, he's certainly pretty keen on keeping 33 in that group of people. So in the same ICU, our general answer is 36, but for certain specific patients, I guess we're opting into 33. I think that's where practice in my ICU is sitting today.
I have strong views. As usual. We have a very large cardiac arrest program in my unit where we, for a long time, we've been performing hypothermia. And believe it or not, even for patients with shockable rhythm, it's not yet standard practice, at least in Europe, for many, many different units. And when people started to get out and say, hey, another negative study, I think it was really important to highlight the fact that this was not a negative study, because both groups were already treated with some sort of hypothermia. We are still looking at some very selected patients. I'm convinced, based on data we've published in circulation, that the patients with non-shockable rhythm actually do not benefit from hypothermia. And I would totally echo what David said about heterogeneity of treatment effect. There is some of this in this cohort, despite the fact that indeed there are a lot of patients with shockable rhythm, with early resuscitation, and indeed it's a very, very selected treatment population. I believe that if you say to people, do 34, you may actually get to 35. If you say to people, do 36, then very often you'll realize that you do not maintain 36. So we did not change our practice based on this study. We tend to allow 36 in the patient that have side effects of hypothermia, especially hemodynamic side effects.
Cool, Jack.
So I'm just going to be very candid about all of these studies, because I think you guys selected a group of studies that are incredibly interesting and present all kinds of challenges. So the first thing to say would be to admit is that I practice in two different units. So one's a tertiary unit, that's sort of the university unit. It's kind of like we do everything. And the other is a smaller Veterans Affairs hospital that is functionally a community hospital in a lot of ways. The Veterans Affairs Hospital, frankly, given the way we're nursing staffed, a decision was made that we cannot cool people reliably, that we can't upskill the nursing there. I'm not saying that's the right decision, but I'm saying a pragmatic decision was made. I'm going to try to ignore that part of me, except when I feel like obliged to disclose it, and pretend I function exclusively at our high-functioning university hospital. At the university hospital, I think we cool intermittently, and when we do, we tend to go to 36 because it's more achievable. I don't know. I think hypothermia is something I desperately want to work. I find outcomes after cardiac arrest so awful that when Stephen Bernard's paper came out, I wanted to be persuaded. And so I think we adopted that quite quickly relative to how we've adopted some other things with similar evidence bases, as we'll talk, for example, in two papers. For this justified us taking a kind of softer approach to hypothermia, which is something we don't do clearly nearly as much as Jean-Daniel does.
So what we'll do now, with my able assistant here, is just go back to the results of the poll, because the panel haven't actually seen them. So we're a little bit confused. We don't quite know whether we're in percents or numbers down the side, but we're going with the fact that it could be a percentage, which says that just under 80% would call their patients or keep them at about 36 degrees at the moment. So, but there's still some around 15% who would cool them down lower. So, and yeah, a few who just don't worry about it. So interesting. Now we do have the ability as well for questions on Twitter, but also for questions from the audience. So if you do have a question or a point you want to make, raise your hand and we've got a microphone that Nick will run to you. So if you're down in that corner, that'd be great. So any questions at the moment?
I mean, I'd say one of the things that kind of came up in the conversation is there are times where you do something because what you're trying to do is discover new practice, right, where you're sort of at the front end of the innovation curve, and there are times where what you're trying to do is avoid doing something wrong. And I feel like this is very much a paper, and frankly, much of what we're going to talk about is going to sit in that tension, because I think all three of us and everyone in the room kind of imagines themselves as a front-end person, right? Like we're doing the stuff they're going to be teaching about in 5 years, but much of the large-scale RCTs are about kind of bringing in the tail and saying about what is no longer acceptable for you not to be doing. And so I think this kind of suggested that you at least need to be having a strong, thoughtful conversation about your temperature tomorrow.
One of the things I've learned this morning is when you have patients that are really too sick to be saved, no strategy will work. And on the other end, when you have patients that are not sick enough, the effect of the treatment may not be easy to detect. And here, as you pointed out, a lot of the patients were had early CPR. And I suspect that some of these patients are probably to be kept sedated because they probably started to awake maybe in the cath lab. This is not the vast majority of the patients you see. I think that if you really focus on the patient with shockable rhythm, they are the patients for which the evidence today is the strongest. Some of these patients will be treated, they will have initiation of CPR later than in the paper, and I suspect that these patients may actually benefit from 34 or 43 as compared to what we've seen in the trial. So for us, this has been a good reason not to change our practice. And I don't think it's so hard to do.
So Jean-Daniel, can you teach me for 30 seconds why you think that?
Yeah, I mean, exactly as you mentioned this morning. I think that the longer the no flow time, the stronger the likelihood that these patients are going to have a detrimental outcome. And if you're just looking at the number of patients that will have favorable CPC scores, indeed, if you're looking at patients that undergo CPR right away, it may not make such a big difference because if you have 34 or 36 degree. Whereas if you are looking at a patient that have a greater likelihood of having unfavorable outcome and CPC scores, maybe these patients may be protected by hypothermia. There's a lot of experimental evidence in support of it, so it's not totally incorrect. And indeed, in patients, again, with shockable rhythm, the evidence is quite solid. There's not a single paper that demonstrated that temperature does not matter in this category of patients.
So there is, I guess, a biological criticism of this, that they weren't cooled quickly enough. So I think, but then again, they probably got cooled as quickly as they probably may well be cooled at our own ICUs, I think. But it's entirely legitimate and appropriate to, I think, process the results and apply them in your own setting. So if you work in two hospitals, as Jack just mentioned, the answer may be, I think, slightly different. So I do like the pragmatic argument that if you aim for 36, you might end up with a surprising amount of time up around 37. So maybe if you're fanatic, it depends on how fanatical and successful you are at achieving 36 and your ability to know that. But there's also, I guess, a pragmatic safety argument. If you go a little bit over-enthusiastic with 33 and you get into a serious bradyarrhythmia in and out of our situation, you can argue, I think, fairly persuasively that you wouldn't have to have too many patients get into that situation before your treatment effects were sort of gone away, really. But overall, I come back to this is a good part of the world to have a cardiac. I mean, it was an excellent study. Really rigorous, subjectively described neurological management. So when and why and how they would, what constituted a basis for withdrawal. So that was a particularly strong feature of this study. So I think it was excellent. As homogeneous as you can make it, neurological prognostication, and I think it really does make, even whatever we might think about temperature, I think if everything else around your cardiac arrest care is excellent, I think this study is strongly positive to show the benefits of doing everything else well.
So David, we'll remind you on Sunday morning at about 6:45 that it's a good place to have a cardiac arrest. Dave Pilcher.
Yeah, I've got a question for the panel. If this study tells us that temperature or hypothermia possibly doesn't have an effect, could the previous studies have shown an effect because what we did was cool and sedate patients for a number of days and delay our prognostication? Is it that we just give time to allow us to get a better neurological assessment of patients? And if that is the case, if we switch to 36, do we run the risk of prognosticating too early and disadvantaging patients?
You responded already.
Body language.
So would it have made a difference if the studies were conducted in a different order too? So the Nielsen paper actually preceded the others and there was knowledge.
No, I think that it's an interesting comment about the timing of prognostication. If you actually cool your patient, it does not mean that you will delay prognostication. Especially if you rethink the way you're treating these patients. We've changed the way we sedate these patients. For instance, these patients have a specific sedation protocol as compared to all the other ICU patients in the unit. And what we found is that it does not delay prognostication. The only thing it actually delays, it's the advent of post-cardiac arrest resuscitation syndrome, where in the absence of cooling you would see this patient with shock status within 6 to 8 hours. And these tend to be delayed by, I would say, 12 hours in the patient that have been cooled. This is the only thing that has changed. Otherwise, we tend to, as I said, change our sedation protocol using really short-acting drugs. We do not mandate muscle relaxant anymore. And the other thing that we do is in the patient that do not show any significant neurological improvement by day 3, we do N20 and EEG and N20 evaluation, and that actually works.
So this is sort of the intracerebral hemorrhage argument, right? So the data on ICH is pretty compelling. That when we look at the scan, we see the big white spot. We go, oh God, no one could possibly survive that. Panic and withdrawal, and that there's pretty compelling data at this point that if you force people to give them 72 hours to 7 days, our best estimates of prognostication are substantially different than what our first ones are. And I do think when you're thinking about nothing versus some cooling, that clearly transfers prognostication. I think cardiac arrest patients provide a bit of, from my colleagues, and sometimes for me, a bit of emotional discomfort. And so people tend to want to come in there and just solve that quickly than be able to sit in that tension. I think sitting in that tension is part of our job as intensivists. That's what we get paid to do. But not everybody's willing to do that, and some people jump the gun. And so I think some form of cooling does force you to just slow down.
But no, I think everything that I've seen, the 72 hours, which was often talked about, I think is certainly at the bottom end of the range of what's a reasonable time to wait now. It used to be sort of maybe in the middle of the range. So if the patient's not otherwise sort of dying from cardiogenic shock or something like that, if they're quite stable, I think the ballpark of how long you should start to wait, I think starts at probably 72 hours these days. Yeah. But you're absolutely right, is that anything that accidentally makes you wait a bit longer is possibly going to enhance the accuracy of the prognostic process and possibly the outcome of the patient themselves.
Okay, we've got a couple of questions over this side of the room. Craig?
Yeah, Craig French. I'm just going to paraphrase Ian Roberts from 1998, who told us that albumin should only be used in the context of a properly designed randomised controlled trial. And in survivor terms up there, the tribe has spoken. 80% of us are now using controlled hypothermia, controlled pneumothermia. To the panel, why should the true believers in controlled hypothermia be allowed to practice as they are, and should controlled hypothermia only be applied in the context of a properly designed randomised controlled trial?
Nice question.
We could probably all take a crack at this. So if you went out drinking with Steve Webb last night, the answer is, well, you should design a really big platform trial and give over control of large numbers of your decisions to the platform trial. That may or may not be the right case. In the United States, I have no concerns that said platform trial will be funded anytime soon, so I don't have to worry about that. I think you're asking, Craig, the kind of hard question of when are you allowed to do stuff because you kind of think it's going to be right, and when can you only do stuff in really a very careful setting. And for me, part of what's exciting about cardiac arrest medicine is this is the former case. The outcomes are so dismal that when I step away from standard care for plausible physiologic rationale or for one or two trials, I don't feel that bad about it because I'm pretty sure they were going to die otherwise. I say, which is markedly different than my colleagues who are taking a clot out of a left anterior descending artery, who should really only vary if they have spectacularly good reason, because their properly protocolized mortality should be spectacular. We just don't have the infrastructure to randomize every cardiac arrest patient to hypothermia or not.
Yeah, no, I think, Craig, that's a tough question. I think it's difficult in both directions. So we know numerous examples where if you try to homogenise and decrease variation in care when the science is not quite good enough, that will have many unwanted effects. So if it becomes unacceptable to do something which is genuinely controversial, we may disagree on whether something's controversial or not. So I think prematurely putting rigidity around what you should or shouldn't do until the science is until everyone's pretty happy with the science is a problem. Yeah. So I don't think this intervention, it remains legitimately controversial for some patients at some times. Yeah.
I may not have understood exactly the question. What I've seen is that most people, and it's difficult to see, are comfortable with 36, which is not normothermia, at least not in mammals and humans. So it's already hypothermia. Whether you should go lower again, it's a matter of debate, and you could say it can be done only in the context of a clinical trial. I think that again, if you target the right patient, there is a patient category for which we are not going to even apply hypothermia because the patients are arrested, yes, outside of the hospital, but indeed had witnessed CPR right away, and when we take the patient to the cath lab, the patient is already trying to self-extubate. There's no point at putting this patient to sleep for 24 hours just because there was a New England Journal paper saying you should do it, published a couple years ago. On the other end, when you know that the patient has been for a timing which is virtually unknown, by the way, at least in my country, we don't really have solid data telling you the timing between collapse and the start of CPR. you know that the first rhythm was shockable rhythm. If this patient does not have any manifest and significant side effect of hypothermia, I don't think that I'm a criminal if I'm doing it.
Okay, question down the back here.
My question really is what are you trying to achieve? Are you trying to achieve neuroprotection or intercerebral pressure control? Because there is overwhelming evidence now, clinically, if you cool people following trauma, you kill them. There's a higher mortality. The recent Eurotherm trial has shown there is a massive increase in mortality if you cool people. So what are you trying to achieve? Is it neuroprotection? And if you don't achieve your target temperature within 2 hours, there is no neuroprotection. Or are you trying to achieve ICP control?
So can I ask you to repeat one part of that question just to make sure I understood it? And I'll plead my dumb American accent. I thought I heard you saying that in your view there's overwhelming evidence that if you cool people for cardiac arrest, that results in higher mortality.
Yeah. I mean, the Hutchinson trial, I admit in the pediatric sense, there was a double mortality in the kids who were cooled. The Eurotherm trial, recently published in the New England Journal of Medicine, so it must be true, showed a much higher mortality in the cooling group. So there's evidence now, if you cool people, the mortality is increased in trauma. Now, ischemia I accept is different.
Sorry, in trauma.
In trauma.
Okay,
so ischemia I accept is different. I accept that completely. But in the context of trauma, you increase mortality. Now, in ischemia, I'm like yourself. I want to believe it works. But actually, the evidence isn't really there.
But it's a different disease. Okay, cardiac arrest is not trauma.
I accept that completely.
It's totally different, and we have further evidence showing that indeed in TBI hypothermia may not be that good. But in cardiac arrest, it's a different thing. By the way, you made a comment which is very important. Indeed, if you target neuroprotection, you want to do it quickly, and if you want to do hypothermia, indeed, I think you need to invest in hypothermia. A couple years ago, we used to do hypothermia with ice and ventilators. Now I have to confess that indeed each patient that undergoes cardiac arrest and hypothermia in my unit costs 850 euros for the equipment that we are using. But on the other hand, when we're looking at the outcome of these patients, it has changed over the years. I mean, in '98, we published the New England Journal paper where we actually did take this patient in the cath lab. And everyone was saying, oh, you're crazy, guys. And now it has changed significantly over the world, and people tend to go to the cath lab. And if you look at the outcome with incremental benefits of different interventions, it has changed. So I don't think that it's a scandal to put 850 euros in an equipment to cool these patients.
But really, enthusiastic temperature regulation might just be a proxy for enthusiastic, positive sort of management of this sort of patient group. So I think whether it's going to the cath lab, whether it's putting a compression CPR device on, or whatever it is, I think if you focus on a problem and you just try to do everything that you do better, good things are going to happen. So I agree. There's a lot of talk about regionalisation of cardiac arrest care. That you should, like a little bit like going to a cath lab. If you've got a blocked vessel, you should go to a hospital that does a lot of cardiac arrest. So I think it very much is mainstream now. That I've probably been too negative about cardiac arrest patients in the past, and that's compared to the way we are now.
Okay, so just to show that we've mastered all the technology at our fingertips here, we've got one question from Twitter, if I can read it, which is, what temperature management, if any, do you use for your non-shockable rhythm cardiac arrest? And if you do, for how long?
Those patients are now randomized into a clinical trial.
Ooh, dodging the issue. David?
I'm waiting for that trial.
Okay. Jack?
Waiting for the trial, but in the absence of the trial, have tended to just put them on the same protocol. Okay. Not feeling good about it, but...
I guess there's a significant more opinion in that question than what we've talked about so far. The pragmatic answer may well be, are you convinced it's going to be harmful to do that or not? So maybe in the absence until we get new information. Maybe the pragmatic thing is to just pretty much do it to everyone, really.
Yeah, and I work in a MICU, so shockable rhythm goes to my cardiology unit. I get PEA, who we know have a dismal.
Okay, I thought my job was to actually moderate this lot, but it's more the audience. Colin, one very brief. Otherwise you don't get the microphone back.
I just found it important to point out that Eurotherm was a study of treatment for high ICP administered after it was demonstrated that cerebral edema had occurred. So only a very small proportion, I think 2 or 3%, something like that, were treated within 12 hours of injury, and that's completely different to what's been done here in a different disease process with very early initiation of essentially prophylactic treatment to try and actually intervene in the evolving brain injury process. So they're really just not comparable.
Thank you.
I think pretty much everything we do could help someone, harm someone, or be ineffective depending on who and when and how we do it. So you've got to pick the right balls to hit.
Okay, great discussion. Moving on. So our next study is the Proceva study, again published in 2013 in New England Journal. Oh, getting ready.
Less contentious.
Yeah, obviously. Looking at prone positioning in patients with severe ARDS. Okay, this was undertaken in 27 centres in France and Spain, so it must be a well-controlled...
He wants to interrupt you.
Already?
So is there a question here?
Obviously not. Moving on. We'll see if we can find one or two just for you.
I'm going to go prone during the presentation.
Yeah, okay.
Improve the blood flow to your brain, too, right?
Obviously know all about ARDS and proning, but not rugby, so it's fine. So looking at adult patients with severe ARDS, there was 474 patients randomised, 466 in the analysis. And what they did was prone them for at least 16 hours in the intervention group quite early on. I think they were proned about an hour after they were enrolled. Quite early, wasn't it? And then proned every day up until day 28. And they also used lung protective ventilation in both arms. So pretty evenly matched, the two groups, in terms of ventilation at the beginning, and pretty reflective of current ideas in lung protective ventilation. And pretty sick patients with significant ARDS. They got on average 4 proning sessions, so they were dosed 4 times on average, and had an average prone of about 17 hours out of the 24 hours. So this study showed a significant mortality difference between the two groups, quite a significant mortality difference, and we'll talk about that. In favour of the prone group, and again just Kaplan-Meier curves to show you that too. So get your phones ready, now is your opportunity to have your say. So what do you currently use, or do you currently use prone positioning in severe ARDS? You can't vote, John Daniel. Never, because it's absolute nonsense. Only as a rescue therapy for patients who have really severe oxygenation issues. Sometimes as an early therapy, regularly as an early therapy, but you do it for less than 12 hours. And your other option is regularly as an early therapy for more than 12 hours.
There's no option for never do believe it works, is
No.
there?
So we'll have a look at the results of those a bit later on. In the meantime, should we be suspicious of such a huge treatment effect?
Yes. So, this, I think, comes down to kind of your fundamental belief as to whether the world is good or not. And
I thought you were going to say round.
My belief tends to be, after having been an intensivist, good things are not out there sitting around like this. I feel like very clearly that if I was a fellow in 2013 when this came out, I would have adopted it and I would have berated every consultant who didn't flip people. But instead, when I was a fellow, I got to sit through the first 4 rounds of negative trials. And so, I think if it's too good to be true, it maybe is.
David, do you want to comment first?
Sure. So I So I'm getting to the stage of being old enough to see things come and go and then come back again. So I think
over 30.
It's a compelling result. No, it is a compelling result. And I think so. My own ICU, we were doing this, and then we sort of stopped doing it in the mid-2000s. But I've got to say, I mean, I was last week. So we're an ECMO place as well, so there's a lot of other stuff going on in the background of care. No, I think I know what this is a French study, right? So I think we haven't had enough raging nationalism in the presentation so far. Whereas hypothermia was there was an Australian study. So I think we do have to. There's a real open question for what to do about this now. So I think maybe I would say the clinical community in Australia was generally not doing it across the board much. I'm sure there are units that are doing it, but as of this study now, I think I probably am more persuaded than not that it should be being done more.
Routinely or more?
Probably more. I mean, I think there's a tendency to throw all the salvage things in one bucket, so each unit will have something they go to when conventional ventilation is getting a bit tough. In my unit, that's ECMO now, but it may have been nitric in years gone by. But I think no, I mean, it's got a compelling physiological basis. It has, although there were some reasonable studies that had no difference. This is big and good. But it's come from a part of the world which is also pretty, everyone's pretty paralysed. All the units were...
not everyone.
Not the staff, but they talk about the hospitals being very familiar with doing it in the first place. So these are not hospitals in their run-in, sort of learning sort of stage. No, I think it's a non-scientific factor. A lot of interventions, if they're laborious or tricky, or we find them a lot of work for us, there's a regression towards the lazy, really. So I think we have to try to not penalise an intervention too much. I mean, the classic for that is SDD, right? So it's meant to work, and we just don't do it. But no, I think I actually had a patient last week who I ended up tracking on Friday, and I must say they were not ECMO material, but I was wondering this week whether I should have prone them. So I think it probably does deserve to have a big look at.
So do you prone at all in your unit?
No, we haven't prone. So many of our advanced trainees are in the audit. So I think you can't just. I couldn't have done it, say, last Thursday because we'd need a process to build a team, get some leaders. So I guess there's a bit of a hump to do one patient safely. So you really got to commit to it if you're going to do that if you're not currently doing it.
The French opinion?
Just say the Americans are right.
Do I have 5 minutes?
You can have 5 minutes.
So first, regarding paralysis, I have to say that the only people I've seen really paralyzed in France is our national rugby team. Sorry. They are paralyzed every time they play, and this is even before the ACCCCN starts. Let's get back in time and history, because also I realize I'm getting old. In the early 90s, we were doing ECMO. And the whole community was telling, guys, you're crazy. You're doing ECMO outside of a randomized controlled trial. 25 years later, people jump on ECMO, and I haven't seen a convincing randomized controlled trials to support that. Let's think about prone positioning. And I can show you, here is written E, but that's my answer to the question you've been asked. As David pointed out, the physiological rationale is there. I mean, read Luciano Gattinoni's papers, and Luciano is really smart. I mean, usually it takes me 2 years to understand what he meant when I read a paper. And believe me, I do paracetamol before because it gives me a headache. And that was before the New England Journal paper. The physiological rationale is there. And we've seen underpowered trials that ended up being negative. A subgroup analysis of these papers actually led the investigators that are doing this. I have to confess, I was not one of the investigators, but I was chairing the DSMB. it led the many investigators to subsequently alter the protocol, studies after studies, proning early, proning for a longer period of time, and proning the patient that had a low PO2 FiO2 ratio. So the patient target population have been better defined, the way to do it has been better defined, and you end up with a clinical trial that shows benefit. And we as a community should say, oh yeah, but it's too good to be true. I think that if we really mean this, we have a problem. However, there is a but in this answer, and the but comes from one thing. I hate the proposal number, it was B, only as a rescue therapy for patients with critical oxygenation. Oxygenation is cosmetic. And when you prone a patient, some patients are going to improve oxygenation because of improved redistribution of blood flow. And some patients are going to improve their oxygenation because of lung recruitment. And again, if you read also the physiology studies, there's one paper published by Luciano Gattinoni in 2003 in Critical Care Medicine that shows that what predicts outcome is not a response in terms of oxygenation, it's a response in terms of CO2 after 8 to 12 hours of proning without any change in minute ventilation. And if you have a reduction in CO2 or CO2 doesn't change, this patient actually survive, whereas the patient that have either that have a minimal change in CO2 or an increased change in CO2, this patient die despite the fact that this patient had improved oxygenation. That's a proxy for looking at who is improving their oxygenation in terms of lung recruitment as compared to blood redistribution. So in my unit, we prone patients when they reach critical oxygenation conditions, and we check what's going on in terms of CO2 and also functional residual capacity measurement after 10 to 12 hours. And based on that, we decide whether they are going to have several sessions of proning or whether it's just cosmetic and we stop proning despite the evidence. Take-home message for me is that despite the great food that I had in Auckland, I can still go and buy a suit anywhere and it's going to suit me. For the difficult patients, they probably need something that is really tailored for them, and you should bring sound physiology back at the bedside. Not every single answer can come from our cities. I'm done.
It's a quick 5 minutes. So a question from Twitter. If we can't believe this treatment effect, and it's been published in the New England Journal, which we should be believing, why can't we believe it?
So I guess I probably I invited this. So I think, so I would steal, I'm going to quote Gordon Rubenfeld badly here. So any time you order a test, you don't interpret the test in isolation, right? So if I drew a gas on John Danielle right now, and he had a PaO2 of 45, exactly no one in this room would intubate him and prone him, right? Because we'd say, something's wrong. Neil might, but the thought of paralytics is not unappealing on occasion when you have to debate him. So for me, I think this is one of those studies that I find really challenging, because guarded within itself, it's a meticulously conducted study, elegantly reported, done really beautifully. So on its own ground, if I had no other information, if I was a pure frequentist, yeah, I would flip everybody, and I would actually be very judgmental about John Danielle being wrong about his interpretation of this as evidence for customizing. However, neither of us are actually interpreting a single paper. Like we would never interpret a single test in the absence of a broader totality of evidence. And for me, there's a long string of proning trials that have suggested about which I'm ambiguous at this point. Before this came out, I felt very comfortable that I didn't need to prone people. Now I feel like I do as a part of my rescue therapy, and I'd like to see this confirmed, because there are two stories you can tell. One is the story of progressive science, which is 8 trials where we slowly get better at a therapy and slowly get better at refining our targets. And we do that, and this is the culmination of this that shows us who the right patients should get the right therapy for. Another is that we had a therapy with kind of marginal benefits and a group of adherents who believed it, who tried 8 different ways to get it to work, couldn't, then got it to work once, and possibly because of chance, unusually largely. And if it's really this big an effect, this should be an easy to replicate trial, and we should be able to see this really easily. I sit in attention as to which of those I believe.
Yes, there are videos on the journal of demonstrating how it's done. I think the authors are at pains to discuss that if you're going to do it, you have to do it properly to get safety. So I think the risk of if this were to say to get translated into sloppy implementation in a without careful selection of the patients, that would potentially translate into a very different real world performance from the performance inside of the trial setting. But no, so for me last week, even though I do find this, I can't ignore this result. I'm not saying I don't believe it either, but it was still the wrong answer for me last Thursday in my ICU to try to suddenly whip up a team of enthusiasts who hadn't done it before and try to get them to do it. So I think you've got to commit to it and do it properly.
We could come and teach you if you like, David, but there's just a question over there. Just here, Nick, in the front.
Lance Armstrong won 7 Tour de France's, and we thought that was too good to be true. The last time we saw pathophysiology that made sense and a trial that demonstrated a 16% reduction in mortality was something like activated protein C, and that got a recommendation A as well. The elephant in the room, though, is it's not easy to do, and we're always worried that we're going to do something wrong when we prone people. And from reading the paper, what I understood was that there were low adverse events reported, but the adverse events, more than 80% of those occurred early in the study, and then once they did it a lot, they got it right. The worry for me is that if we translate a sort of 32% reduction down to 16%, and we say that so everyone should prone, and you only do it once a year, we're not going to get it right first time, and that might be the only time we do it. So is the worry that we get a result from a study that was doing it all the time transferable to the general population?
Good question.
I got to say, I think that this is a generic problem. Right, so this is, if you're going to try APRV, if you're going to put somebody on ECMO, you probably shouldn't just go to a weekend course of the mountains and then just try to do it for the first time, notwithstanding what some of our colleagues upstairs might tell you. But I mean, actually, I think this is a pretty easy one to do well compared to some of the other stuff we do.
So that's a great question. Prone positioning is not rocket science. Okay, nursing protocols can get this really fairly right, and if you do it within the indication that are recognized today as being reasonable, you're going to do it a certain number of times. What's going to change in your unit is the number of patients that are going to go on ECMO.
So just to follow up then, if nurses decide to turn patients left and right based on the physiology,
would you be happy if the nurses just proned them without talking to you?
No. That's so no. I'm telling you, this does not happen in my unit. I mean, that's a medical treatment that goes with a medical prescription, and when the nurses actually do it, at the time they are ready to do it, there's a doctor that comes, and again we measure physiology before, physiology after, and we try to understand whether for this particular patient this intervention is beneficial. But we do record. We have it's a fully computerized ICU where we do record all the side effects of this type of procedures and the technical complications. And I can tell you that since 2006, the number of complications have been minimal, except in the patient that didn't have the right indications. And here I'm going to follow on what Jack said. The trouble I have with prone positioning in my unit are the residents or the junior, the attendings that forget that this patient doesn't have ARDS. And indeed that this patient is hypoxemic, but it's cardiogenic shock. And that prones this patient and this patient arrest. So literature is there to be read. My father-in-law used to say the papers will never refuse ink, and he was right. But it's also there to be interpreted correctly.
I mean, it's probably no more work or more unsafe than taking a patient to CT, an intubated patient to CT. Though spending 16 hours face down is a long time. I think ultimately it really depends if it works. I mean, I think the way maybe a rational position in 2015 for me right now is I think selection needs to be smart. I mean, I would say probably consultant level selection of just the right patient, and then do it properly with teams that have done it before and practice it. So I think it would be a very good sort of training project and quality improvement exercise to maybe retrain up our people to do it properly. I think as an ECMO unit, I'm probably obliged to absolutely exhaust everything up. So rather than let's just put them on ECMO, I think that's probably the wrong thing to do. So I think that highly selected patients, and then if you evaluate, and then you may specifically choose not to. So if someone's got raised abdominal pressure or something else, you may not want to do it. So a high quality patient selection process followed by a high quality implementation, and then evaluate it. So then to maybe stop doing it if it doesn't seem to be doing. But I certainly wouldn't be comfortable with a unit protocol that said if their ABGs reach this number, you've got to do it.
Okay. Question over here.
Yeah, hi. Lizzie Skinner from Western Health. I certainly take some of the points that have been made previously during the conference about the heterogeneity of treatment effect and the different methodology and looking at a body of research. But we're also doing trials for the purpose of patients and patient care. And my uncle was admitted to an ICU with H1N1 early last year. And of course, I wanted, it was after the ProSaver trial had come out. And I certainly wanted him to be offered early prone according to the ProSaver protocol. So I'd invite the panel to comment on if your family member was in the intensive care. Would you like the ProSaver protocol followed if they had ARDS?
Just an answer, not the whole history.
No, that wouldn't change my opinion.
Definitely yes before ECMO.
So if they weren't already doing it and familiar with doing it, I would say no. If they were, yes.
Yeah. Can I just ask you the other question to that, which is if a family asked you to prone a patient, will you?
Yeah, no, it's never happened. I think...
I didn't ask you that.
I'm just saying, all right? But no, I think I would fall back to what I just said. I think that I would probably have to... I would be very happy to discuss it. I would say I'm aware of this data as well. But as of today, we're not currently honed and doing this right now, and I don't think it would be advisable to do that in a hurry. But I think I think it's a very legitimate thing to ask about. But, no, I think that's a completely reasonable thing to ask.
I work at a cancer center and a transplant center. People ask me for things all the time. Some of them are medically indicated, and if I truly felt like I was on the fence and my nursing staff felt like they were, the nurses I had available to do it felt like they were okay with it, yeah, I'd be happy to let that patient preference sway me. If I didn't think it was indicated, or I thought given the actual bodies I had in the unit at that time couldn't do it well, then I'd say that.
So it might be the same conversation around vitamin C as well. David Tuxon.
Look, I think we all recognise that the proning works by lung recruitment, and I think we all need to recognise that this is good data, but everybody's voting with their feet. Most people aren't doing it. And I think the other major thing we haven't discussed is that the reason is that this trial compared a lung recruitment method with no lung recruitment. And there are other ways of doing lung recruitment. And I think a lot of us don't prone people, because, and I'm one of them, because there's another way of recruiting the lung that's far easier. And that is a better alternative that a lot of us are taking up than proning, or an alternative that may have equivalent value. And that hasn't been investigated and hasn't been discussed. So I put this to the panel. Why not just recruit them with a high-level recruitment and then instead of proning?
Very, very fair comment. But if you look at the data from LungSafe, 13,000 patients, including 4,000 ARDS patients, and look at the PEEP levels. When we have meta-analysis that have shown that for the most severe patient, they should have higher PEEP level. The average PEEP level are lower than the lower arm of the ARMA FiO2 PEEP algorithm. So we have a strong tendency not to do what we should be doing.
Thank you. Right, we're going to move on to the next couple of papers.
I'm very sorry, Naughty Corner, that we're not going to let you ask another question, but you'll have more opportunities. So I was the lucky winner of the driving pressure paper, which, Jean-Daniel, your question about taking 2 years to understand something is probably about where I'm at. So for those of you who haven't read this, this was published in the New England Journal earlier this year. So the components of a protective lung strategy: lower tidal volume, lower plateau pressure, and high PEEP. The studies that have looked at this, and which there are multiple, have had conflicting results, and perhaps some of that's due to the manipulating one, and it's hard to work out which component works, because you manipulate one, you may affect others in the opposite direction that you don't believe is beneficial. So the authors of this study hypothesised that driving pressure, which they've said is tidal volume divided by respiratory system compliance, or defined as plateau pressure minus PEEP, is possibly a better thing to measure because it is more closely scaled to the available lung than tidal volume based on ideal body weight. So that's the plateau. So that's how they define it: plateau pressure minus PEEP in a non-breathing patient. So what they did is they got all the pooled data, all the individual patient data from the 9 ARDS RCTs, which is 3,562 patients, and looked at their outcomes. They performed, the primary outcome was 60-day mortality, and they performed multivariate analysis, which was stepwise and backwards. They also used a statistical tool called multi-level mediation analysis, something you're all very familiar with. So the idea of the multi-level mediation analysis is that it's applied to randomised controlled trials. The goal is to determine whether a specific variable strongly affected by treatment group assignment has an effect on outcomes that explains in whole or in part the effects resulting from the treatment group assignment. So what they're saying in these low tidal volume studies was the survival better explained by specific ventilatory variables than treatment group allocation. And they looked at tidal volume, plateau pressure, PEEP, and driving pressure. So what did they find? The good news is you won't hear any more stats in this interview, this session. The driving pressure was most strongly associated with survival. So for each 1 standard deviation increment, which was about 7 centimetres of water, there was an increased mortality with a relative risk of 1.4, confidence intervals that were significant. Great. They then resampled, and these are very carefully prepared slides to make this make sense to everyone. So they've regrouped all the patients and analysed the outcome, and what they've shown here is that as plateau pressure goes up, if PEEP stays the same, so driving pressure goes up, there's an increased mortality. So plateau pressure goes up, driving pressure goes up, there's an increased mortality. That's probably what you'd expect. However, if you then control driving pressure, so plateau pressure goes up, driving pressure stays constant, and PEEP goes up, magical arrows come, and there's no effect on mortality, suggesting that the constant driving pressure equals flat mortality, and that the plateau pressure was an independent variable, which is what they showed in their analyses. So they also looked at a matched plateau pressure, so keep the plateau pressure the same, and then get different decreasing driving pressures, increasing PEEP. We could have a quiz and you have to work out what happens, but you know, mortality goes down. So a lower driving pressure is associated with a reduced mortality, even though plateau pressure stays the same. And then finally, they did tidal volume based on predicted body weight with a steady plateau pressure, and so showed that there was no difference. So as tidal volume went down, if plateau pressure stayed the same, there was no mortality benefit, whereas when they looked at tidal volume on respiratory compliance, with a steady plateau pressure, there was a mortality benefit. Simple statistics, easy to understand and apply to your everyday life.
And explain.
So, that's right, and explain. That's the good news, is at the end of that bit. So, here are your questions. What are your current ventilation volume pressure targets for patients with severe ARDS? And while you ponder that, we'll take it to the panel. So, someone has said that post hoc analysis is the soft porn for statisticians.
Those people should get out more.
What do we do with this?
Don't like it. Yeah, no, I think excellent authors. The constituent studies are great, but it's obviously it's not a primary piece of work. It's a interesting think piece, really. So I think its implications for clinical management right now are probably minimal. But it's, I mean, we do tend to worry about the things that we can see. So we can see peak, we can see plateau pressure, but what we really want to know is, I guess, is transpulmonary pressure, but really factoring in the chest wall and all these other sorts of things. No, they're very legitimate things to talk about. They're probably really important physiologically. But I think ultimately this is for, I think this is, I'd be happy to be persuaded otherwise, but I think this is for aficionados. I think compared to the issue of, if I had to choose between doing delta P and actually knowing that everyone in my ICU is actually receiving lung protective ventilation, so we know that in just the translation of just common garden low lung protective ventilation, even in ARDSNet units, you know, if you go around and actually look at an ICU that's just done a lung protective ventilation study, they can just slip back to sort of bad old ways of higher mils per kilo. So no, I think the big question is, I think the bigger, more important question is just implementing, I guess, the convention a bit more thoroughly rather than this. That's my sense of this at this stage. Yeah.
Come on, guys.
Yeah,
I mean,
so all of us are kind of having a side conversation here. So one of the brilliant things that got shown at NUSA last year, this year, was the point prevalence survey, which is one of the just brilliant things that ANZICS does. And it showed that you guys apparently are just unpersuaded by ARMA, by the low tidal volume paper. And so one of the interesting questions for both this paper and indeed the previous paper was both of those are based on the pretty compelling data to at least some of us up here that 6 cc's and 30 is more evidence-based and probably better than, I don't know, 8 to 10 and sort of some peak number we decide on. But there's a strong Australian practice to be right in the range that Dale Needham has suggested is associated with increased mortality. So I think one of the hard questions to think about that I don't have to worry about, but you guys all have to sit in, is when you don't believe the low tidal volume component of all these trials, what do you do with data that's predicated on the low tidal volume component? Second piece, do I think this proved that I can, in the places where a delta P limited strategy as opposed to a P-plat limited strategy would give you different answers, which isn't maybe all that often. Do I think that this lets me willy-nilly go to the delta P? No, I do not. If I'm stuck violating a P-plat, do I maybe sleep a little better as a result of this study? Yes, but I think that's a intensivist anxiety management evidence base. That's not the same thing as saying I would intentionally violate a P-plat of 30 in order to abide the study result.
This is not a study. This is indeed a thoughtful interpretation of previous studies and reanalysis of previous study with statistics. Today my answer is definitely A. There's a but always. I have many Australian friends and friends from New Zealand that have convinced me that when you have good study question, you should actually do a clinical study. So the ventilation arm of PREPARE is testing whether indeed it makes sense to target your ventilation strategy based on driving pressure or not. That's one of the ventilation strategy we are testing. At the bedside, again, I speak a lot about at the bedside, and you may think that I'm just flying airplanes. No, I take in-house calls several times a month. At the bedside, the question I want to, and I'm asked by the residents is, okay, what PEEP level for this particular patient? And I think that the answer is it depends upon the potential for recruitment. Here again, if you read the literature, there's a recent paper that have shown that if you just look at the severity of illness based on the Berlin definition with a PEEP of 5, instead of with a clinical PEEP or with any type of PEEP, you're going to get the best distribution in terms of mild, moderate, or severe ARDS. And the patients that are deemed to have mild ARDS with a PEEP of 5 have a greater potential for recruitment as compared to, no, it's the other way around. The patients that have the severe ARDS with a PEEP of 5 have greater potential for recruitment as compared to the patients that have moderate or mild ARDS. So already, if I evaluate the patients with a PEEP of 5, I can have a guess on as to whether these patients will benefit from PEEP. And then I test it. I put a PEEP of 15, and I look at changes in PO2 FiO2 ratio, changes in CO2, and changes in compliance. And I can define this way which patient is more likely to benefit from increased PEEP strategy and sometimes accept a driving pressure of 12 or lower and higher PCO2 level as compared to the patient that will probably not need it nor benefit from it. So again, the mild ARDS patient, it's no problem. The severe ARDS patient, I think that they require today something more than clinical trial. They require sound physiology at the bedside, and this is why for the moment we are still having doctors in the ICU in France. With the 35-hour week, it may change.
So Jean-Daniel, can I impart, just to get us going up here a little bit, let me take the counter position. In particular vis-a-vis the question that where we don't have clinical trials, our physiology can somehow inform us when that physiology has a pretty darn spotty record of translating as a good surrogate endpoint into mortality benefits. So when we don't have the clinical trial data, I mean, yeah, I use the physiology too, but I feel awful about it. Right? The physiology argument for fixing PCO2 was really, really compelling until 2000.
So I fully agree. That's why we study it. I think that when you don't have the evidence, but when indeed the situation is frequent enough to be studied and recurrent, we should study it. We should not just say, oh, I rely on physiology, period. Especially because students know nothing about physiology today. So.
Oh, don't let those two people on the microphone.
Yeah. Wait, somebody else who hasn't talked yet has a question.
I'm just picking up on something that David said earlier, and that's the impact of chest wall compliance. And certainly, restricting the plateau pressure to 30 has been around since as long as I've been in intensive care now, well over 20 years. But it's not so much a European problem, Jean-Yel, but certainly in Australia and New Zealand and the United States, our population is growing in size, and there's an increasing prevalence of the obese patient in the intensive care unit, whose chest wall compliance is dramatically different to a thin patient. Can you tell the audience how you ventilate the morbidly obese patient, what driving pressure do you use, and what plateau pressure do you accept?
Okay, I'm going to start. Great question. If you want me to go and tell you, oh, we are using esophageal pressure measurements, no, we don't. First, it's complicated. Second, the evidence. I would have loved to discuss this paper. The Talmor paper, what a joke. Published in the New England Journal, 30 patients in each group, primary endpoint, PO2 FiO2, oxygenation, stopped early for benefit. In 33% of the patients, they would not even succeed in put the esophageal pressure balloon. It's a joke. So how do we ventilate these patients today? Very difficult. What we do at the bedside, we measure functional residual capacity and try to see whether indeed there is some amount of recruitable lung. We are ready to accept higher plateau pressure in these patients, but we don't exceed 6 ml per kilogram because indeed I believe that today it's the best evidence we have.
So I'm from Michigan. We love us some big people. We have one very charismatic member of our department who would totally agree with everything John Danielle said while putting an esophageal pressure monitor into him. And so they're replicating the trial actually at scale, kind of the way it should be done. And so that'll be very interesting. I think the striking thing from my experience of randomizing a lot of patients has been how often we're using the esophageal pressure monitors to turn down the PEEP. Because we'd go on, oh, that guy's 350, 400, I don't know, you can do the math. That's a lot of kilograms. And that finding that actually we had over-PEEPed them wildly. Based on that, like, I don't know, they look fat, give them more PEEP. I think it's challenging. The bedside assessment of chest wall resistance is challenging.
Jeff?
Jeff Shaw from Christchurch. I want to put a slightly iconoclastic view to suggest that the ARMA study was one of the most deeply flawed studies ever in the history of intensive care. The reason I say that is that if you look at the data, it showed that 12 mils per kilo killed people. It wasn't 6 mils per kilo that saved people. And Catherine Deans, in an editorial in Critical Care Medicine in 2005, said that the patients who were not randomised, the people that were for whatever reason were excluded from the trial, had exactly within about 0.2% mortality of those that received 6 mils per kilo. So I've always felt that we have misinterpreted this study and that the evidence of 6 mils per kilo just isn't there. And what Marcello Amato is really saying is that we need to ventilate patients according to the available lung that is not collapsed or atelectatic within the lungs. The heterogeneity, just because of people's size, because the mils per kilo, predicted body weight, is only 20%. If you go back and look at the original data from the ARMA study, the heterogeneity of compliance is 1,000%. So why the hell do we ventilate patients according to body weight? We should be ventilating them according to available lung, which is based, as best we can, on the compliance of the lung. And the best way to do that is to use driving pressure and use nothing else. And that is the argument that comes through this paper. And I think it's a very potent argument if you take that in context of the original assumptions and the original design of the ARMA study.
So let's separate for the moment the question of kind of the fairness of the ARMA comparison arms from sort of the second point about how should we drive them. For the first one, I'll simply say people have their views on it, and I'll refer you to essentially every American Thoracic Society meeting between the year 2000 when it was published and the year 2010 when they finally banned the pro-con debates as to whether the control arm was a fair control arm or not. We're not going to move anybody. I think for the second one, the answer is mid, right? Like, it kind of depends how much you believe kind of our physiologic argument is going to get us right. At this point, I feel like I grew up in a time of getting burned by compelling physiology that failed to replicate in RCTs. Other people, not so much. I think we need that's a testable hypothesis that desperately needs to be tested, and it sounds like it is going to be tested in PREPARE.
I would say that I'm in the middle. During my time at the head of the European Society, I've been fortunate to travel a lot and to visit a lot of intensive care units. And I can tell you that there are many parts of the world where 12 ml per kilogram or even more is the current ventilation strategy with a respiratory rate of 12. So that's still happening, and I'm convinced that this is probably deleterious. Knowing whether 6 is better than 7 or 8 is a different question. And again, I would ask you, read the Q-Mello paper, still Luciano Gattinoni's team, Blue Journal, 2008. Take 2 aspirin before, it clearly shows you that neither tidal volume nor plateau pressure are adequate surrogates of the risk of ventilator-induced lung injury. And if you want to assess this patient per patient, then you need to measure functional residual capacity, and you need to estimate stress and strain. I believe that for a given tidal volume, if a recruitment maneuver, as if it was suggested before, or increasing PEEP result in increased functional residual capacity, it means that it's going to result in decreased lung stress and strain. And I agree with Jack that maybe physiology does not always translate into mortality benefits. But if I was in the ICU myself, not my family, if I was in the bed, I'd like to be treated by someone that knows physiology in the absence of evidence.
Yeah, and so I mean, the way I would put it, if I was going to rank if I was going to rank the study questions that I think need to be answered in sort of ventilation today, yes, I mean maybe an RCT of a delta P based strategy would be on the list. But if say two investigators came to me and one was an RCT of exploring this hypothesis, and the other one was an observational quality project of knowledge translation to make sure, a package of stuff to make sure no one in my ICU is getting, say, more than 10 mils per kilo or something, I would probably plump for that. So I think the magnitude of good, if I was going to bet on where the magnitude of benefit is going to be for the bang for the buck, I think just making sure that no one's getting really big volumes consistently, and no matter what the time of day is, no matter who's on, I think you're probably going to save more lives by doing that well. So to me, that's the bigger question: is why aren't we even in teaching units and units that have done ventilation studies? Why do we still have? It's pretty easy to find patients who still get a pretty big tidal volume.
Okay, thanks. So we are running a bit short of time. We have got one more that's a bit quicker, light-hearted, esmolol. So if you can bear with us, we'll quickly go through it.
Was that a horrible pun about the esmolol and the light-hearted?
Slow-hearted.
So the use of beta blockers in sepsis could be considered a balance act between the possible benefit to patients by decreasing the deleterious effects of catecholamine stimulation, like in heart failure, versus the harmful effects of depressing myocardial performance and precipitating cardiovascular instability. This single-centre, open-label phase 2 study randomised 77 patients with septic shock requiring high-dose noradrenaline. They'd had 24 hours of hemodynamic optimisation to esmolol IV versus placebo, and the aim was to maintain a heart rate of 80 to 94 for the entire ICU stay. They also used pulmonary artery catheters and levocemendin as an inotrope if needed, so very similar to standard Australian practice. And this is what they found. So firstly, they enrolled only 52% of patients who they screened had a heart rate 48% had a heart rate greater than 95, so the rest weren't eligible to be in the study because they weren't tachycardic. They were mainly pneumonia, peritonitis, and they were receiving 0.4 mics per kilo per minute of NORAD at enrolment, so they were pretty sick. They achieved their target heart rate goals, so the esmolol group stayed at 85, the control group was 105 for the first 96 hours, and that was presented as area under the curve. The mean arterial pressure was maintained in the esmolol group, and surprisingly was associated with a significant decrease in noradrenaline compared to control. Stroke volume index decreased, cardiac index increased in the esmolol group, and the significant difference in 28-day mortality of 49.4% compared to a whopping 80.5%. Again, very similar to Australian ICUs. So that's 91%. Oh, 28-day was 80.5%. So, there's your question. Would you consider the use of beta blockade in a tachycardic patient with septic shock on vasopressors in the ICU? I can answer the first question. John Danielle, what are the Italians doing? 80% mortality, PA catheters, levocemendin, esmolol. No wonder they're broke. I know there's a bit of a recovery going on, but you know.
I don't know what they smoke, but it's very uncommon. very special.
Guys, the utility of a single centre, small number trial study with high control group mortality, any comments?
Yeah. Of course, we did not believe it, so my answer is still A. And what we've done was we looked at because when you discuss with the Italian, they tell you, yeah, but these are patients, they are very severe. They are very, very severe. So we took exactly the same inclusion criteria and looked over 10 European ICUs, what the mortality rates of these patients were in our ICU, because 80% is not what we have for bone marrow transplant in our unit. So, and not surprisingly, none of the 10 ICUs had those type of mortality, the mortality rates reported in the control group. So
did they have it in the treatment group? Like, did it get I mean, those are remarkably high numbers.
Yeah. So,
given the trouble Far Left's having enrolling, apparently you could enroll in a week.
We do not believe it. We tested whether indeed they had a funky sample. It seemed that they had really a funky sample, and real mortality rates in the control group.
Dave, you look pretty calm over there. I'm like a man on beta blockers.
Yeah,
Do you?
It didn't really pass my sniff test. I think starters, targeting heart rate tachycardia is a therapeutic target in sepsis. That's just not, that wasn't on my radar, so it's one of those ones that sort of comes out of left field for a start. So you're already sort of rocking back in your chair and crossing your arms before you and then the study itself, no, it does, I think it's just, it is hard to believe. I think the control room mortality is unbelievable. Single centre. No, I think so. It doesn't really, it doesn't really pass my front line to actually start to engage and have a bit more of a serious think about it.
Okay, Jack. Before you answer, John Daniel's just got a.
The real question is, why is this published, and why is this published in this journal? And I think that this
you
is.
Best friends with Derek Angus?
I was his best man at his wedding, so I suppose we are best friends. But no, but. It means something for our community. It means something in terms of what are the drivers, for improving patient care, academic progress, and so on. I think that this is an important question because the papers will not refuse ink. If you published it in a good journal, you will always find crazy people to jump on the bad things and less people to actually do the right things.
Yeah, and there's the practical issue. Infusing that much esmolol, I don't think it'd probably be possible in my hospital. So I think there's there's esmolol maybe in the operating theatres, and not the big dose ampules. So I think if I attempted to do this, the pharmacist would probably.
But that's a solvable problem.
Yeah, of course it is. But I think but as an obstacle, a practical obstacle is why, and one more reason why this wouldn't. I don't think it'd be seriously taken up if other hospitals listen. But I think. I think it's just hard to believe. I think I think there is. I think publishing it in such a high-profile journal is quizzical.
So I totally agree that this is nuts, and under no circumstances do I think I'm smart enough to give a catecholamine and an anti-catecholamine at the same time. And somehow, particularly when I go home at night and I leave some poor 25-year-old to try to titrate those with the night nurse, for that to work out well for my patient in the morning. Yeah, this is clearly the sort of thing that if you're going to do it for the first few times, you have just bought yourself a bed right next to the patient's wife, and you're going to be in that room for the rest of the time. For me, what's fascinating about this is thinking about this versus Prosiva. Prosiva has an order of magnitude more patients, and that's a very important thing in limiting bias. But when you hear, for example, John Myberg has a lovely podcast from SMAC on exactly this from a year ago. When the folks talk the physiology of this, it's a thing of beauty. And when Merv Singer, the senior author, gets up there with his slides and the things are doing this and it's coming out and there's the little happy Microsoft guy, and you're like, Merv Singer's a genius. He understands the body at a level I just don't. And so I feel like one of the challenges of this is I looked at this and said, oh God, no. but I feel like it's hard for me to understand why exactly I felt so much more confident with that "oh God, no" than I feel with seemingly when I have equally smart people making similar claims about physiology at a deeper level than I am able to evaluate that evidence. And I sit in that tension. I feel like that's why this is a really interesting article.
Can I just ask you, half the room would give beta blockers, not clearly not quite the same way, but there's, cautiously for tachycardia on a patient on low dose of vasopressor only. So if we accept the study's what it is, there's some plausibility in the room to the idea that slowing heart rate and sepsis might be good for you or something. Anyone want to make
So
a
to be
comment?
clear, you guys would put them on 10 cc's or 9 cc's per kg and give them some esmolol?
No, so the question is, would you consider use of a beta blockade in a patient with septic shock in the ICU?
So what this tells me is that Mervyn is a wonderful actor and that you like this show.
It's a great show. If you haven't seen the Merv Singer show, I strongly recommend
But
it.
it's a show, and his unit was part of the units, the 10 units that were in the study I just referred to. So,
sort of secondary to that question, and maybe our poll result is, do you think these trials, even if we don't accept their result and say, I will apply Proceva, they change our mental landscape? And they make something that we would not have considered now maybe something that we do consider. Are these results good or bad, or whether history proves them to be the first step in something that later becomes proven to be part of our practice, or something that is there for a week and and history proves that it was totally wrong? And we've seen big trials that have gone both ways. How does it change our kind of culture, what we deem to be crazy and what we deem to be something that's maybe now not crazy, it's just something, we prone patients much more than we used to. We don't prone as per Proceva, and now we get babies on bronchiolitis, we prone them. They're totally different. We've got no evidence on that. But because it makes physiological sense, and I read these papers and sort of understand them, and for maybe a week or an hour, and then have to reread them again 6 months later. It changes the way I think about things. Now I think proning is something that's out there. It's not silly. I understand that smart people think it's good, and there's some evidence that you can learn to do it well. So maybe I'll use it as part of my armamentarium, but not necessarily in the way the trial described it. And how do all these trials change the background, the landscape of ICU?
I think clinical science is the basis of improving everything that we do. Whether or not, even if we think something's got a big methodological problem, it still doesn't invalidate the enterprise of using clinical science to improve care. I think there's absolutely no substitute for all of us having to be, I guess, sophisticated users of information ourselves. I mean, there's 3 suits on a table here, sort of thing. But I think ultimately we all have to have an ability to understand and apply a piece of evidence to our own patients, and that's not sort of going to. And given the volume of studies that are coming out, I think our ability, we're all going to have to be trained as users of information. But no, I do understand what you mean. I think the whole point, when a trial shows a counterintuitive result and turns out to stand the test of time, that's really important. I think that's the whole. That's the whole point.
I think it's a great comment, and in relation to Proceva, I think that it seems very important in this part of the world. It's obviously less important in France. If you want to do me a service, I'm looking at Craig. You're the chair of the CTG. Do Proceva study, do a prone positioning study, stratify on the response in terms of CO2, and next year, knowing that you have a research powerhouse, you'll have the answer, and you will be able actually to convince the world that it's not only something that works in France.
We'll let you get the last question in, and then we'll call it a wrap. So it better be good.
Craig Carr, I now work in New Zealand, but I used to work in the Marsden in London, where we had a lot of neutropenic sepsis bone marrow transplant patients, and we had a usually 60% survival to discharge for a good few years. not discharged from ICU, discharged from hospital, sometimes in second bone marrow transplant patients, sometimes in people that were both ventilated and filtered. And we would periodically give people esmolol infusions if their heart rate was running along at 140, 150, and we had no other means of bringing things down. And similarly to the study, found that the stroke volume was going up. We started doing it, obviously with a great deal of reservation, because there was no big evidence base, on the basis that we saw if patients were going along like that for several days, despite us bringing their temperature down, despite the antibiotics, and we still had 4 or 5 days before the transplant took, that they would often go into terminal cardiac failure. And so bringing the heart rate down was helpful. It's counterintuitive to use beta blockers with noradrenaline, with vasopressin, occasionally with adrenaline going on too, in which case it became almost madness to me. But then more recently we got ivadribine. And would the panel have the same reservations in using ivadribine in this circumstance? Going back to what you've been saying, it's the by the bed, examine the patient, stay with the patient, assess the physiology, do the echo, look what's happening when you've reduced the heart rate slightly. But beta blocker versus noradrenaline versus ivadribine versus noradrenaline, would the panel feel happier in that circumstance? Because you're skiing off-piste anyway.
I'll admit I have no informed opinion about that. I'm actually failing to parse the drug you're mentioning into sort of something I think of how I'd order, so I am uninformed.
Same reply. I did not actually understand the name of the drug. Not available.
You know, I think that's in the art of medicine category at the moment, I'd say. But yeah, I mean, if you got a very, yeah, I think we all do things that we probably can't find a trial for. But no, I don't. I'm not sure. I don't have an answer for that question.
All right. So thank you very much. Thank you, speakers, for giving us your time.